IMA Tiswadi members. Can you hear me?
Yeah, loud and clear.
Okay, right, great. So at first outset, I think we welcome all the members, and I would like to thank Dr. Amit Dias for having accepted our invitation to speak on something which is very dear to our IMA State President, Dr. Geriatrics. It's a beautiful slogan of care for the old with the heart of gold. And I think it's probably the need of the hour, where we can see a lot of social issues with old people, not just physical, but a lot of mental issues. And who is better than Dr. Amit Dias to have, give us some ideas about how we can approach this problem. And throughout this year, this is going to be the target for the IMA State President. And personally, as IMA President of Tiswadi, also I would like to support this cause. And I welcome all of you for having joined it on Sunday. All the credit goes to my secretary, Dr. Salil. He's going to take this forward. And thank you very much and enjoy the evening.
Yes, thank you, Dr. Mahendra Kuttarkar. Again, on behalf of the Executive Committee of IMA Tiswadi, I extend a very warm welcome to all the IMA members from across Goa who have logged in tonight. A very good evening. Friends, the theme of the IMA Goa State this year is on geriatrics. And in keeping with the theme, in sync with the theme, our topic for today is care of the old with a heart of gold. Goa is one of the states which is facing this unique problem where the younger generation have migrated to other countries, gone out of the state, out of the country, in search of lucrative jobs, in search of greener pastures, leaving behind their parents and the elders at home who are lonely, bored, and sometimes sick. The sickness may be sometimes physical, like diabetes, say, or heart ailments or kidney problems. And sometimes it may be mental, like Alzheimer's disease or dementia or depression. So the problems are multifactorial. They suffer from physical, mental, emotional, and even financial problems. So what can we, as doctors of the Indian Medical Association, do to salvage this situation? How can we bring solace to this elderly population? How can we bring a smile on their face? This is the question we are posed with. To take the same matter forward, I would first our IMA Goa State President, Sir Dr. Rufino Montero, to kindly guide us on this issue, to give us his vision for the year 2022 in the respect of this theme of the IMA Goa State, and to address all the members of the Indian Medical Association who have logged in tonight. Dr. Rufino Montero.
Hello, good evening, all my dear colleagues of the IMA who have joined in for today's webinar, where Dr. Amit Dias, who is a consultant in the Department of Preventive and Social Medicine, Goa Medical College, will be speaking to us on care for the old with a heart of gold. As Dr. Dalvi just spoke and told us the importance of this topic, this theme that we have taken up for this year at the IMA Goa state level, we feel that there is a lot to be done for the elderly in Goa. And in view of this, we have decided to organize state level CMEs by every branch on the various problems faced by our elderly. Maybe orthopedic problems, cardiac problems, psychological problems, and various other problems that they face. Besides this, we have started with the idea of educating the youth in Goa, in colleges, in youth associations, youth clubs, on the importance and ways of taking care of the old. For this, we are making a presentation which will be given to every branch of the IMA in Goa, so that we have a uniform presentation to the youth on this important subject. Besides this, all the IMA branches in Goa, in various regions, have got old aged homes looking after the elderly people. We Hello? Hello?
Sir?
Yeah, can you hear me?
Yes, sir. Yes, sir.
Hello?
Yeah, yes, sir. It's clear now.
Hello?
So you're audible now.
Okay. So as I was saying, in every region of Goa, we have old aged homes looking after the elderly. And all the 7 branches of IMA Goa, we are requesting them to look after and see which are the aged homes in their territory, reach out especially to those which are needy, provide medical care by not a camp that sometimes is done just once in a year, but a regular medical checkup of the elderly, so that we can maintain and upgrade their health, give them help during emergencies, and do a social service, especially to the needy and of course to all the elderly. We have also asked all the branches now to organize various social activities or certain activities in these aged homes to make the. Can everybody hear me? Anand?
So yes, sir. Yes, sir.
Okay.
Yes, sir, you're back,
So
sir.
There
go
is
on.
some technical glitch. So we are asking all the IMA
Yes, yes.
branches in Goa to organize activities and otherwise to lighten the mood of the elderly in these aged homes and in the elderly in their areas. And on 1st October, which is the International Day of the Elderly, we will be having a big state level function, especially designed for the elderly, so that we give importance to the care of the old, a heart of gold. And I request all my IMA members to come up with any further suggestions that would be useful for taking this theme forward and for the care of our old. Thank you. And we go ahead with the talk by Dr. Amit Dias. Over to Dr. Anand Dalvi.
Sir, thank you so much. And thank you for those inspiring words. Now, coming back to the topic, our guest speaker for today is an expert at geriatric medicine, an epidemiologist, and the assistant professor, Department of Preventive and Social Medicine, Goa Medical College, and our very own IMA Tiswadi member, Dr. Amit Dias. Dr. Amit Dias completed his MBBS and his MD in Preventive and Social Medicine from Goa Medical College, Goa University. He then studied Tropical Medicine and Hygiene from the London School of Tropical Medicine, UK, followed by Geriatric Medicine from Ramaiah Medical College in New Delhi. He also was awarded the Caetano Dias Fellowship for postgraduate diploma in geriatric medicine in Bangalore. He has several research papers to his credit in national and international journals. He has done a lot of social service, especially for the elderly in the area of Alzheimer's disease, for which he was awarded by the state government of Goa on Liberation Day in 2018. He has co-authored on Lancet on prevention of dementia and Alzheimer's disease. He was the honorary chairperson of Sangat, an NGO dedicated to mental health across the age spectrum. And it was during his tenure that they won the prestigious Public Health Champions title in 2016. Dr. Amit Dias is also the founder secretary of the Dementia Society of Goa. He has been involved in several research projects such as rabies, on Japanese encephalitis, iodine deficiency disorders, rheumatic heart disease, and diabetes. Tonight, as already mentioned, is going to talk to us on care of the old with a heart of gold. Presenting to you, Dr. Amit Dias.
Thank you very much for that introduction, Dr. Anand. And at the very onset, I would like to congratulate the entire IMA team led by Dr. Rufin Montero, Dr. Mahendra Kuchatkar, and Dr. Anand and the whole team for choosing such a wonderful theme. It's very timely, it is very essential, and there is a lot that you can do in order to reach out to the old, to care for them, and that too with a heart of gold. It's the one thing about reaching out to the old in your clinics, but really, if you have to reach out to the old with a heart of gold, it has to be beyond your clinics. And how do you reach out to them beyond your clinics? Because that is where these services needed the most. And this is, you're going beyond your boundaries. And how to do that is something that I will try to explain to you. And because there's a lot for you to do, there's also a lot for me to talk on this wonderful topic. And so I thought I'll just categorize this to help us understand first why we need to care for the old. And then I'll give you some examples of certain projects that we did and how we went beyond the boundaries to reach out to the old, especially for those in need. I'll be taking the example of dementia and Alzheimer's disease because this is a complex condition. A person with dementia has a medical condition, has social problems, have a lot of behavioral issues, have issues related to caregivers. So how do you address a complex condition like this? And that too not going very much beyond something. We came up with a model that can actually be expanded and can be integrated with primary care. The other project that I was involved with is the DIL project, incidentally also called DIL and the Heart of Gold type of thing. But DIL stands for Depression in Late Life. And it's about how we can prevent depression in late life by addressing chronic conditions. And I'll speak about how we evaluated this and how we had to come up with innovative ideas in trying to reach out to the old to be able to address this issue. The third project that I'll be trying to speak about is something called the Integrated Care of Older People. This is the WHO's new initiative on how we need to reach out to people, but not singly. We need to do it integrated manner because elderly have multiple problems and also have multiple needs, and therefore they have to be addressed by multiple disciplines and how that teamwork can be done. A little bit about what the government is also doing, and you will be happy to note that your objectives and the objectives of the government are actually in sync, and we don't have to reinvent the wheel. We can coordinate with the government services to be able to reach out to the old in a much more effective manner. And really at the end, I'd asked a group of older people what they want the IMA members to do in order to reach out to them and help them out. And they gave me some replies, and I want to put that out in the last slide on what the elders want the IMA members to do. So it's going to be a lot of things. Let's see how we can cover up. You need to understand first that it is a large population that we're dealing with. Now, in India, we have more than 1 billion people. But what is more important for us to understand is that the aging population, we're undergoing this kind of a demographic transition. The aging population is rising much, much faster than the rest of the population. And therefore, the needs of the elderly are also something that we need to cater off. If we want to see how big this thing is, I'm not putting too many numbers to get very confusing. We want to see how many older people are there in the world today. It's around 1 billion. That is equivalent to the population of our country, almost equivalent to the population of our country. So that is how big the population is as of now. And what is more important for us to understand is that this population, or this segment of the society, is going to increase tremendously in the years to come. And what is even more important for us to understand, you can see this from this slide, the dark red represents the low and middle income countries, countries like China, countries like India, where the rise is going to be very, very fast compared to the rest of the country. So this is something that we need to definitely gear up for and develop services that can deal with problems with the elderly. Our life expectancy is increasing, and we can see that right in front of us. You have countries like Japan, US, where the life expectancy is 85. There is a little more that they can do, and there's a limit to how far they can take that. But our life expectancy, which is around 70, we can see with the advances in the medical management, you have people with critical cardiac ailment that can be cured, a person with cancer that can be cured and has a very good quality life. So our life expectancy is going to increase tremendously. 80, 85 is something that can happen very soon, and therefore you will have a larger population that is in the geriatric age group. You can see this rise in the slope that is there in India, and in the years to come, this is something that we need to really cater for. Goa is in a much better state than the rest of the states. And as Dr. Anand was saying, a lot of people from Goa, the younger generation, migrate abroad, and therefore the elder population tends to stay here, and so we tend to have a larger population above the age of 60, which is what we need to be really geared to cater to. Now, we need to put a cutoff somewhere, and therefore the WHO has said that 60 to 69 is something called the young old, and they're not like the old, they are young old. 70 to 79 is categorized as the old, and 80 and above is categorized as the very old. There are these terms called geriatric, and when you talk about geriatrics and geriatric medicine, this is a branch that is dealt with by the medical fraternity. It's a study of disease that affects elderly and attending to the diseases that affect elderly. There's also a branch called gerontology, which is a medical study of aging and processes and policy, etc. So you'll have social scientists that are involved with this. But everything put together, you'll understand that it is not only to be addressed by medical doctors, but also by the nursing staff, also by the physiotherapists, but also by the occupational therapists, social workers who have to go, and this kind of a team effort that needs to address the problems of the elderly. There's a term called ageism that is spoken about, and something, ageism is a systematic stereotyping and discrimination against people because they are old. And this can be also self-discrimination. That is, I feel I'm not so good because I'm now 60 years old. That could be self-discrimination, or it could be discrimination by someone else at the job, etc. Something like sexism, where you have discrimination based on gender. And this is something that we need to avoid in our society. Now, coming to the other important question is who cares? And Dr. Rufino very clearly said that, if the IMA members want to reach out, this is a low-hanging fruit. We have around 40 old age homes in Goa, 9 old age homes by the government. And we definitely need to reach out to them. I had tried to classify, in which talukas, how many people are there in each of these old age homes. And a total of around 1,361, if I can see that slide here, are living in old age homes. So majority of people who are above the age of 60 are living in the families. There is a small proportion that is living in old age homes, and these people are in need. And then we can, as IMA members, can actually adopt different old age homes. The bigger cities have more number of people as compared to the smaller places. But this is, I think, the first thing that we can actually do is reach out to people in the old age homes, and then think of how we can reach out to the rest of them. I'd also done some studies on who cares in the community, and majority of the elders, as I said, live in the families, but the family system is breaking up. The joint family system is no longer there. Everyone is working. Even the women in the household are working, which is a good thing. But what happens is if there is an elder with special needs, then it becomes difficult for them to cope up with an elderly person in the house. The care arrangements for this elderly person becomes a problem. We have this syndrome called pickup, which is parents in India and children abroad. And this is exactly what Dr. Anand was referring to. And it is a big problem in Goa because a lot of people are in the Gulf or in other developed countries, and the parents do not want to go there. They want to stay here because this is the place of their birth. And if they have a problem, then it becomes difficult to deal with them. There are a lot of notions about aging, and they are kind of negative. They are kind of saying that when we grow old, we don't want to be dependent. So a lot of people say that we want to live long, but we don't want to grow old. And when they mean that, what they mean by that is that don't want to be dependent. And so that should be what we try to aim to do as IMA members, try to see how we can improve the functional ability of an elderly person, how we can improve the functional ability, because that is exactly what they're looking out for. The most frequently reported health conditions, joint pain, diabetes, cardiovascular diseases, and family issues also. There's social issues, and usually when we did this in-depth interviews with a lot of older people, there were a lot of interpersonal problems, and especially problems arising with the daughter-in-law and mother-in-law type of issues, which brings about a lot of conflict, a lot of financial issues sometimes, which sometimes lead to elder abuse. And this is kind of a mixed bag that we have to address. What we can see, and this is a study by the ICMR, we see that older people, they don't come with one health problem. Sometimes they come with multiple health problems. They tend to have multiple conditions. And these conditions are also chronic. So you'll have a person with hypertension and diabetes and heart disease. Most common condition is a visual problem that people have, as you can see from this, but then arthritis, cardiovascular disease, neurological problems like Parkinson's disease or Alzheimer's disease, respiratory problems, psychiatric problems tend to be very common. GI related problems tend to be very common. What we need to understand is that anytime they come to us with an acute condition, we need to do what is called a comprehensive geriatric assessment. We need to assess them fully to see if they have any other underlying condition. They may not even know that they have this condition. So you need to do a comprehensive geriatric assessment and then try to address these problems together, because there could be one problem leading to another. If there is a visual impairment and you do not correct it in time, because of that visual impairment, he may have a fall, as a result of which he'll have a fracture, and then that will lead to some other problem. So that, one thing leads to the other. Because he has hypertension, you put him on some medication. Those medications can give him some postural hypertension, which he was not kind of aware. It was not keeping that in mind, as a result of which there's a fall, and that could be a problem. So we need to make sure that we try to address them completely. And this brings to a very important part of assessment in the geriatric age group, which is medication. Very often you'll have people collecting medications for the last, say, 10 years from different doctors and taking them, and so they will take some medication of that kind. So you need to ask them, what are you taking? Best to tell them to get those medications with you, and you do an assessment, see whether what they're taking, is it really required for them? Very often they take the same medication of different brands. They're taking in the wrong dose, or they're taking some medications which could have actually stopped, and they're taking it for a longer period, which is not really required. So address the findings after you do a comprehensive geriatric assessment. Prefer simplification for them, prefer less toxic drugs and other options. So always assess the patient again and assess the medications that they are taking, and then go forward with them. I remember when we were speaking, just like, geriatrics, there is something called pediatrics. We all more familiar with that. And when our classes on pediatrics were taken, always, I remember Madam Meena and Madam Mimi always would tell us, a child is not a mini adult. Similarly, an elder is not a mega adult. They are frail and they behave differently. Just as a child behaves differently, the elderly people also behave differently. They have health problems that could affect children. They have health problems that could affect the adults in middle age. And they have their own health problems like stroke and dementia and Parkinson's disease, etc. But the way they present could be different. And we have seen that very clearly, even the COVID pandemic. A person with a respiratory problem may not really present with cough. He may present with, there could be the secretions that collect over there. There could be hypoxia, as a result of which the person will present with some ataxia, or will present with altered sensorium. So we need to be able to correlate these and be sensitive to these different ways of presentation. And therefore, when Sir said that there will be several CMEs now to build capacities of our members itself to be able to detect these health problems in various systems, that is the best way forward, because we need to build capacity. We are going to reach out to the old with the heart of gold. We need to build our capacity to reach out to the old with the heart of gold as well. COVID was, a big problem, and I think the one age group which COVID has affected the most is the elder age group. The virus itself was very harsh on them. There were more hospitalizations in this group. There were more deaths in this group. And even the measures that we took to curb COVID were actually affecting the older people, like lockdowns and social distancing, etc. I know people who are staying indoors for the last 2 years. So it leads to a lot of depression, a lot of loneliness, a lot of hopelessness. And this really increases the problems in the older people. So your decision to reach out to the old with a heart of gold is really very timely and very, very essential. Let us see these two examples first that I spoke about. I'll be talking first about the dementia initiative of mine, which we reach out to. It was home-based. We try to detect people with dementia in the houses and try to see what we can do for them. And that helped us then develop the model for prevention of depression in late life. And basically in depression late life, what we try to do is help elders itself take their health in their own hands. Sometimes they're dependent on other people, and then they just keep on postponing their own health-related issues. But when they took their health in their own hand, they could make a difference. And we'll see what the difference is. Coming to the first bit, which is dementia. And as all of you know, dementia is a condition that affects elderly, where you tend to forget, but forget to an extent that you cannot do your daily activities. So that is the level or of the memory loss. So we often forget where we put our keys. We often forget where we put our mobile or a pen or something, and we're searching that. But we do find that a person with dementia will forget where the key is gone, and when they see the key, they may not even know what it's meant for. So that is the kind of forgetfulness that happens in people with dementia, and it is progressive. So if you notice this, any memory problem in older people, one needs to be sensitive and get that person assessed, because it could be dementia, and there could be reversible forms of dementia as well. So dementia is basically this umbrella term that covers up, loss of memory issues in the elderly. And sometimes even in the younger age group, say, for example, frontotemporal dementia and thinking and ability. So it's really cognition that is affected. The various causes of dementia. Alzheimer's disease is the most common form of dementia. Around 60% of the dementia is Alzheimer's disease, and you have vascular dementia, which is like a kind of a mini stroke that takes place, or Lewy body dementia or frontotemporal dementias. Most of these dementias, unfortunately, are irreversible forms of dementias. But what one needs to understand, there are reversible forms of dementia as well. And the reason why I'm mentioning this is because any of these assessments need to be done by an expert. The follow-up care, the post-diagnostic support can be done by any doctor, but the initial assessment has to be done well, because if you miss the diagnosis, then you could miss the reversible form of dementia, and you could actually keep a person, try to treat a person as an irreversible form when actually it could have, that condition could be reversed. Drugs can cause dementia. Emotional problems, for example, a person with depression can present with what is called depressive pseudo-dementia, and if you treat the depression, that can reverse. Metabolic conditions could be there that could lead to dementia. Endocrine problem like hypothyroidism could lead to dementia. Nutritional problems, vitamin B12 deficiency, for example, B1 deficiency can lead to dementia. Normal pressure hydrocephalus, that early interventions are possible. Tumors or trauma, infections, alcohol, autoimmune conditions, etc., can cause dementia. So these things you need to make a proper diagnosis. So comprehensive geriatric assessment is key in addressing the issue of dementia. So what I saw when I was doing my research, in fact, some of you may not know, I got involved with dementia because it was my topic for my thesis. When you're doing an MD, you have all of you know that we have a thesis, and my thesis was on Alzheimer's disease. And I realized that nearly 90% of the people with dementia who lived in the community, they didn't know really that they had dementia. The family itself didn't know what was happening. They thought the person was behaving abnormally, was asking for breakfast every now and then. And there are a lot of behavioral problems that they're complaining about, but they didn't think of it as a disease. They didn't think of it as dementia. They didn't think of it as something that can be addressed, or there's something that can be done for this. So there was a need to raise awareness. There was a need for home-based care, because we realized that a lot of these people were in the houses and not really coming forward because of the condition, not going to the health centers. The home-based care should be also affordable, has to be person-centered for the person with dementia and for the benefit of that person, and should also address, very important, address the needs of the caregivers. So when you are reaching out to the old with the heart of gold, you should also reach out to the caregivers, the people who are taking care of the elderly person in the house. Because if you don't address the issues of the caregiver, then the caregiver will not be able to take good care of the person that you're trying to reach out to. So we were fortunate because at that time, the Ministry of Social Justice approached us and said that they wanted this kind of a package to be developed and what can be done for people with dementia in the community. And this is a photograph 20 years ago. That's me. You can see that right in the 20 years ago. But that's a team, and we were wondering who should we take, who will actually reach out to them. It's not possible for, if we say psychiatrists have to go and reach out to people's houses or neurologists have to go and reach out to people, that will be very difficult to do because they have their own job. In fact, that is the time Dr. Shikovaz had just started the Department of Neurology at GMC, and he was the only neurologist, I think, at that time. So it's not possible for an expert to be going there. Community health workers should be doing that. Can we get lay health counselors to do that link work, who will come back and give a feedback to the expert, and they will help develop an intervention for these families? So that is kind of the model that we develop. The intervention for them can be summarized. It was a complex intervention, and it can be summarized in this acronym CARE, where C stands for caregivers. As I said before, if you do not address the burnout in the caregivers, some of the caregivers were suicidal as well. So if you don't address this burnout in the caregiver, they're looking after this person for the last 5 years, 6 years, 10 years, and it's kind of a thankless job. They don't even know what's happening and don't have the techniques on how to look after such a person. They don't know how to assist the activities of daily living. So that is the training that we have to address the caregiver issues and then teach the caregiver how to take care. A is for activities of daily living. As I said, we need to try to improve the functional ability, and no person with dementia was same. If you've seen one person with dementia, you've just seen one person with dementia. The other person will have different memory. The cognitive impairment will be at a different level. The behavioral problem will be different. And so the package will be different. But there are patterns. And so that is what we try to train them to handle. So activities of daily life, like how to, problems while having a bath, problems while eating, how can you deal with that? If there are problems while sleeping, how do you deal with that? If there are problems wandering, how do you deal with that? So that is the kind of training we gave. R is for reminiscence therapy and for reality orientation. This is really cognitive interventions for the elderly to improve that. E is also very important. E is education, educating the family, helping them to come to terms with what the condition is and to know what to expect. So once they know what to expect, they don't really get paranoid about it and know how to deal with the person. And these catastrophic reactions from the person with dementia and the caregiver also can be reduced. E is also, it's very, very important, the environment. We look at the environment, look where they're staying, if there, if there's anything that can promote, say, predispose them to fall, etc. So we try to change the environment to make it safe for a person with dementia. I remember a family that we had gone to, and the person with dementia was actually alone, and she was trying to prepare tea. So when we went there, we realized the gas was on, and she was trying to light it. The whole house was smelling of gas. And so she was trying to light it. So it could be a danger to her and danger to the other people around if she had to actually light that the gas. The whole house would go in flames. So something like this, which you can say is actually, this is very simple, So what's something great over there? But it is the simple things that make a difference. And we needed the lay health counselor to go to the house, understand the problem, and address these things like a catalyst to make a change in their lives. So eating, dressing, toileting, sleep disturbances, bathing, communicating, and the problem behaviors like hallucination, repetitive behavior, wandering, etc., were kind of addressed through the caregivers. This is some example. So if somebody was having an eating problem, we would go into the details, like, what is it that you gave the person to eat? What time did you give the person to eat? What did the person say? He was not eating at all. What was the person eating before? So we'll ask these kind of detailed questions and then be able to address the issues. Again, issues with regards to sleep. Very often, the person with dementia would sleep in the daytime, and then the family would complain that they don't sleep at night. So when they complain about they don't sleep at night, we could get into a bigger history about, what exactly, a detailed history of what really is happening. And we try to promote sleep hygiene, because if you let the person sleep well, then a lot of things are much better off. There's some more pictures of home counselors visiting homes and trying to address the issues with families of people with dementia. what is very, very important is that the care to good care is actually good communication. So you need to train people to speak to older people if you have to deal with it. Cutting the whole story short, this was an intervention we gave for 6 months. At the end of 6 months, we evaluated what was the effect. And we saw that the stress level, the GHQ score, was telling the stress levels in the caregiver had decreased tremendously to a significant amount. The behavioral problems in people with dementia had actually decreased. The Zarid burden score, the perceived burden of the caregiver in taking care, that had also decreased. And we also saw that the quality of life of a person with dementia had improved, because if you see here in the intervention arm, there were 6 deaths, which are half the total deaths in the control arm. There were 12 deaths in the control arm. So what we did is actually we reduced the chances of a person dying, which means the quality of care had also improved. So this is something very good. I belong to a group or a consortium of doctors which really deal with the same thing, and you have doctors from Niemann's, etc. So the whole focus, it's called the 1066 Dementia Research Group, and 1066 because only 10% of the research into dementia is happening, where actually 66% of the people with dementia live. So we want to readdress this, and we want to do more research, because more research helps in generating awareness, helps in encouraging service development, and helps in shaping policy. And we wrote what is called the Dementia India report, and that is, the picture below shows Dr. Jacob Roy, who was the late Dr. Jacob Roy, because he passed away a few years ago. And he was the founder president of ARDSI, which is the Alzheimer's and Related Disorder Society of India, that gave this policy prescription to the government of India and what they need to do. The second project that I was associated with was the DIL intervention. And this took a step backwards and tried to see, instead of trying to address problems once they come, can we actually prevent the problems in the elderly? Can we actually prevent depression in the elderly by treating the chronic condition, by helping them deal with the chronic problems that they're having? And how do you do that? And that is DIL. DIL stands for, as I said before, depression in late life. And the whole focus was prevention of depression in late life. Now, for this, again, how to help elders take care of themselves, one thing is to engage them. We had to do a lot of storytelling, because it is not, talk therapy, for example, is not something that older people would really appreciate. They would like to speak to people, but not look at talking as kind of therapy. They would say, okay, pilla haduna, it is not, they're not asking for anything specific. They're actually asking for some calcium tablet or some diclofenac gel or something like that, which they want. They like chronically feel that makes a difference to them. But what they need to understand is that if they don't go beyond what they are doing and try to do something for themselves, then there is no difference in their life and in the quality of life. So that is what the DIL project was all about. This is somebody that I really admire, Professor Charles Reynolds. He's a geriatric psychiatrist from the University of Pittsburgh, who University of Pittsburgh was the collaborating agency with me on this project. And he had visited homes of different people. We approach people with sub-threshold depression and try to address their needs and multiple needs. And that is one project. This is again visiting the homes and trying to assess the pills that people are taking, and trying to see why they're doing it and what we can do about that. So basically, what the project did is we did something called problem solving therapy for them. So first, identify the problem. And it could be various problems. It's not only a medical problem. That's something we realized, that it is not, older people don't really have only medical related problems. They have social issues and financial issues, and how you can deal with that. It is not that we're going to pay them anything, but we can at least guide them where they can go to be able to ensure that they get some kind of financial aid, or the social issues can be addressed. So identify the problem is the first step, and then helping them deal with it. Each one had a different problem. And so the interventionists, again, were lay health counselors. People are link workers. Link workers are like multi-purpose health workers. So that is the level of people who would actually go to the houses and then come back to the doctor, and with the doctor try to develop intervention, develop a package that will be delivered to this family. So if they had diabetes, we would deal with diabetes. If they had hypertension, we'll deal with hypertension, or any other issues, we'll deal with that. And they were trained to do that. Again, we evaluated this after 1 year. So this intervention was for 1 year. We had 181 people in this study of ours. And we tried, at the end of 1 year, to see incident episodes of depression. And as you can see from this graph, the blue is the intervention graph, the one that got the real intervention. The black is the one that got care as usual. So we didn't deny anything to them. They got care as usual. But in addition to that care as usual, the blue arm got the intervention. And we can see a definite drop in the scores of depression in this group. And the total number of people, of people with depression in the intervention arm was 4 as compared to 14 in the arm that got care as usual. So we managed to prevent depression to a great extent. This is a photograph. You can see Professor Reynolds again over here at the Mandur Health Center. This is everything happened at our headquarters at the Rural Health and Training Center at Mandur, and we now have a beautiful new building over there. But this is a dissemination thing that we had for the participants, and it was a very touching moment for us because all of them said, doctor, don't stop this. This is a wonderful program for, we've never nobody actually visited us and dealt with these issues of us. I mean, people deal with our health problems, but you went much beyond that. And so this is something that they really appreciated. And we can see from the results itself that it was showing. You can see from this photograph also, everyone was smiling. We got a little more ambitious then. And instead of just addressing dementia, depression, we thought that older people have multiple problems. Can we help them cope with multiple problems? COPE stands for Care of Older People. Okay, Care of Older People is the COPE program, and we started on a very small scale. I thank, in fact, I need to really mention the names of Dr. Shikovaz, Dr. Jindal, Dr. Rajesh Dhume, who helped with the dementia project, Dr. Vikram Patel, Dr. Charles Reynolds, who helped with the DIL project. And the COPE project, I thank Dr. Kedar Raikar, is also a member of the IMA, who was great help to, we wanted a larger sample, and therefore he was a great help to help us cope with the larger sample. And over here, what we did is we tried to help, again, the lay health counselors or the health workers to be able to identify the frail elderlies in the community. So how they can identify that, and then we try to develop. We sat with the members of the WHO, and this is the team, the WHO ICOPE guideline development team. This we sat in 2015, and very recently we have released the guidelines on what can be done to help older people, irrespective, of what condition they have. So they could be having cognitive impairment, they could be having visual problem, they could be having hearing impairment. All these things are affecting their what we call intrinsic capacity. We need to improve the intrinsic capacity. We need to improve the intrinsic capacity, as a result of which their functional ability will improve. So we need to detect this early, and that can be done. The detection can be done by lay health counselors. What the WHO says very clearly is healthy aging is the process of developing and maintaining the functional ability that enables well-being in the older people. So it is not about just letting them live long, but adding life to the years. It is not just adding years to their life, but adding life to the years, which is the focus there in the WHO report on this. This is the graph that shows something similar to what I was saying. So as we grow old, our intrinsic capacity drops in the second half of our life. So it declines and then significantly loss. There's a significant loss after the age of 80 or so. What we need to do, and intrinsic capacity, I'm saying this again, is our physical and mental capacity to do things. So our ability to think, our ability to remember, ability to see, ability to hear, our ability to walk. So if these things are affected, then our activities of daily living are affected. If this is it, and there could be various reasons for that being affected. And that person needs an assessment, a much more detailed assessment. What we need to do is improve the intrinsic capacity. So if somebody is having a visual problem, detect that early and correct it. Somebody is having hearing impairment, try to detect that early and address that. Cognitive impairment by cognitive stimulation, locomotor problem, again, that can be done by exercise and physiotherapy. So try to improve the intrinsic capacity. In addition to that, we also need to address functional ability by changing the environment. Many of you who have probably gone abroad, you'll have a 90-year-old person, frail, elderly, with a walker, or maybe even on a wheelchair. would get out of his house, enter the public transport bus that the steps will come down. He will slide inside. There will be a seat reserved for him. He will go to the shopping market, do the shopping from the shopping mall, come back, sit in the bus, and he knows for guaranteed that there will be a seat for him, and he'll go back home and he'll be safe. But this all happens because the environment is disabled friendly. The environment is elder friendly. So once that happens, functional ability really improves. So that should be the aim, and that is the aim of the ICOP program. The WHO always focuses on what we call active aging, and the main pillar of active aging is health, and that is where our role comes in. If we try to ensure health and try to protect their health, then we can get older people who are really active. The theme this year for World Health or the International Day for Older People was digital equity, trying to ensure that older people also now, because a lot of things are happening on Zoom and a lot of things are happening. You can actually, people can order food on the phone. So they need to become digitally savvy in order to be part of the system. And therefore, trying to train them in this was kind of the aim. So many things can be done in order to address the issues of the elderly. I had a small film. I don't know if that's going to work. If it works, I'll just try that out to tell you a little bit about what the ICO program is all about. Can you hear this? Rohan? Can you hear?
No, I can't hear.
Can't hear, Rohan?
No.
Can't hear?
No.
Okay. So
No,
what I'll
no.
do is I'll stop this.
Video only.
Okay, you can hear the video, you can see the video, but you can't hear, right? So let us skip that video. Okay, let's skip that. I'll try to see if we can. Yeah. So what the video showed is really that a lot of older people have comorbid conditions. And if they have comorbid conditions and they want to access healthcare, they have to go to multiple places. So that becomes a problem. If they could get integrated healthcare, that is the whole aim of the ICO program, the integrated care of the older people. And that can be done by getting healthcare workers to be able to detect the problem early. If you want to really prevent the functional decline, you need to detect these problems early, get them to a place where a comprehensive geriatric assessment can be done. And if that, then you early interventions for them, and that can change the trajectory as far as their functional ability is concerned, and add life to their years. I was also fortunate to be, as this is something that Anand also had mentioned, part of the Lancet consortium for the prevention of dementia, and we published the paper last year. What we saw, this was a meta-analysis that we did of all the research that was done all around the world. And we came up with 12 different ways, or the evidence shows that there are 12 different ways by which we can actually address this issue. And 40% of the people with dementia can be actually protected. We can either postpone or prevent dementia. And these factors are education, physical activity, social contact, something very simple. Hearing loss, we saw that if people do not use, hearing loss by itself does not cause dementia, but if a person with hearing loss does not use hearing aid, that can lead them, because the stimulation is less, and that the hearing centers are also in the temporal lobe, which is close to the memory centers for some reason, we've seen a very close correlation between the two of them. Hypertension, obesity, smoking, depression, diabetes, excessive alcohol intake, head injury, air pollution. These are factors that kind of causes dementia. So we need to address these issues. We need to do what is called cognitive stimulation. And for that, in Goa, we started, this happened when I was speaking to the senior citizens group in Panjim. And they're a very active group. And I said that cognitive stimulation, what you all need is something like cognitive stimulation. So they said there has to be a place where we can do cognitive stimulation. And we started what is called a memory cafe in Panjim, again, run by volunteers. So it's not that I'm going and doing things on regular basis over there. Kind of just gave them the idea, and the volunteers do a superb job. So it's like, it's like music and dance, but trying to add cognitive stimulation to that. So it's one thing about singing a song, but now you're singing a song without looking at the lyrics. And different memory games, and every day it's kind of a different thing. And now with COVID that happened, we then switched on to Zoom because we kind of had to reach out to them. And even Zoom it's working very well. In fact, people had a problem with transport, etc., to come to these places. It was done on a weekly basis. In fact, done on every Monday and every Wednesday. Called they named it Whoopee Wednesday and Magic Mondays. I don't know if you've heard it. People from Panjim might have heard about it. So now it's happening on Zoom on a weekly basis, and we have people from all over Goa and outside Goa as well who join this program and very enthusiastically participate in this kind of stimulatory exercise. In addition to that, we also have health talks. So it's the multiple programs. We have health talks. We have these exercises. We give them exercise and assignments that they do at home and come back and share with the rest of the group. They're encouraged to do different things, like small things like gardening. If they do some crochet work, they will display that on the group and then encourage other people to do that. So it's a very good way by which we can assess help them stimulate their memories. I also ran a program called Mind It. Mind It was for schools, just as you all have thought of addressing. I think it's a brilliant thing to do. Address school children to be sensitive, or address college children to be sensitive to the elders at home. So it's an important one to do. And the Mind It program was to help school children adopt a brain healthy lifestyle. Because if you want to change things in the future and prevent dementia, it is not at the age of 60. You need to change lifestyle much earlier on. And therefore, Mind It was a program. So I used to do it for 7th and 8th standard first. But I've done it for 3rd and 4th standard kids as well, and it works brilliantly well. They're very enthusiastic and very impactful. So that is one thing. It works two ways. One is for the child to adopt the brain healthy lifestyle, and two is for them to be sensitive to the elders in the home. And in case they have dementia, these children can say, okay, there was someone who came to our school and said that memory problems and so on so would be a sign of a disease. Let's get them checked. So if you speak to them about in schools, address them about elder problems in general, I think that's a brilliant way forward to be able to reach out to the families. It's difficult to reach out to families, but reaching out to school is a good way. The other thing that I did is training home nurses. So there are a lot of home nursing institutes, like Caritas is running that, there's Matur Chaya, and there are a couple of others. So address them on how to take care of older people, especially older people with dementia, get them involved in various kinds of health related days for them, for example, the Alzheimer's Day, etc. So when they get involved, they feel connected and they know exactly. Initially, the home nurses were, they would try to avoid looking after a person with dementia. But after this, they take it up as a challenge because they say, okay, I will do it. I can do it. I have it in me to be able to take care of this person with dementia. And I know how to do it. And so that is kind of a challenge that take up, and they're doing a decent job. A lot of awareness activities and various poster competitions, walking on the street, etc. was required. Our students at GMC did a brilliant job every time. And come up with creative ways of trying to address the issues like street plays and things like that, which speak on various aspects, which is what, again, something that the IMA can do this year. You have the IMA students wing now, and the IMA students wing very strong with, we had a run for people with dementia, and always they participate in various programs. This year for World Alzheimer's Day, we colored the bridge, or we lit up the bridge, Atal Setu, in purple, which is the theme color, and really to mean that we need to bridge the gap as far as dementia is concerned. And that is what we are kind of aiming for. The government is also thinking on the same lines. The government is also sensitive to the problems of older people. The issue was which department actually deals with it. So there is the social welfare department and also the health department. So the government came up with, in 1999, came up with a national policy for older people. There is also something like a maintenance. I'm not a really fan of this, but there is a Maintenance and Welfare of Parents and Senior Citizens Act. So if children do not take care of their parents, they can be taken to task. There is a fine. They can be put in jail as well if the parent complains about that. But really, we need to improve the capacity, and the approach should not be a threatening approach, but try to get people to be sensitive to the needs of older people and take care of them, and they need assistance. We also now have, in 2010 onwards, something called the National Program for Healthcare of the Elderly. This is through the Ministry of Health, and really the whole focus here is to add life to the years of the elderly person, to add to give them financial and food security, healthcare, shelter, and other needs of the older people. And through the program, just as you have a program for tuberculosis, or you have a program for malaria, you now have a program for the elderly. And these objectives, I put them down purposely because it really, you'll see it resonates with the aim that you have at the IMA, and you all should not really duplicate work, but work with the health services to be able to achieve these goals. And it's not possible for them to do it on their own as well. So easy access, promotional to preventive, curative, and rehabilitative services in the community, identify the health problems, provide appropriate care and interventions in the community with a strong referral support. So it has to be older people may need the referral support, capacity building, human resource development, train medical doctors, paramedical professions, train caregivers within the family for providing care, and have proper referral support. They have also, in fact, Dr. Edwin Gomes is now the head of the geriatric medicine department that has been started at the Goa Medical College. We have a special ward only for geriatric medicine. The sub-district hospitals also have are now catering to the older people. Every primary health center, and I remember a lot of work done when Dr. Max was in charge of this, and have started a geriatric clinic, an OPD, especially meant for older people. But a lot more can be done in collaboration with more training and a proper. So it's one thing about having a geriatric clinic, but to be able to do a good job with that geriatric clinic. The whole aim was to change the quality of life. So what can the IMA members do? I asked the people at this memory cafe, there are around 100 people, to give their opinion on what they think the IMA members could do to be able to reach out to them. And they came up with various answers. Besides saying food security is something that was coming up in their mind quite often. So, arrange for groceries is something that was really high in their head. Because that is something close to them, and they always fear for the future, what's going to happen next. But I think what can be done is, one, capacity buildings, as you rightly thought, the CMEs for doctors on various topics related to to the elderly, the workshops on topics related to elder care. We can probably even extend and have workshops for nurses, workshops for multidisciplinary departments like maybe physiotherapy or occupational therapy, involve dental health care as well, because this is also something that is important for the older people. Start from your clinic, make your clinic elder friendly. One of the inputs that I got from they mentioned Margaon particularly, saying that the clinics in Margaon are not very elder friendly. They find it very difficult to take an elderly person to the clinic. So make the clinics elder friendly if that is possible. And then go beyond the clinic, like health education in schools. Now with Zoom, it's much more easier. You can have webinars. It's very easy for us to have webinars, very cost effective as well. Observe various days, as Sir rightly said, International Day for Elder, but there are other days also that you can think of observing, like the Alzheimer's Day and Parkinson's Day and Diabetes Day and Hypertension Day, Elder Abuse Day on 16th or 15th of June. So you can observe these days as well. Teleconsultation, telecounseling services for the senior citizens is something that can be done. We've already started through IMA teleconsultation. This can expand to cover up older people as well in a special way. Care of old age homes and adopt an old age home project that Dr. Rupino mentioned was, I think, a brilliant way. But also training the people running old age homes. We had a workshop once, a 5-day workshop on training people who run old age homes. And initially they found it very difficult to come, and they've always created some kind of excuses, no, who's going to be there, and we have so many people to take care of. But when they came for the workshop, they loved it. They said, no, this is a brilliant thing. We were never trained. We're taking care of older people. We don't know how to take care of them. So something like this, a training program for maybe a shorter, not a 5-day, maybe a 3-day thing could be done for building capacity of people running old age homes. We can also train people who are retirement people. So people who at the age of 65 retiring that year, if we have some kind of workshop for them, that would be another useful kind of a training. We can tie up with the government for that. Identify high-risk people who live alone, people with chronic conditions such as dementia. Coordinate with the elder helpline. You don't need to have a separate helpline. I checked this out. 14567 is the elder helpline. This is a new helpline launched by the government. They're going to launch it in a bigger way once the elections are over. And we could tie up, the IMA members could tie up. So they get multiple questions on legal aid and financial problems, etc. But the medical problems could be dealt with by members of the IMA. So we can actually tie up with the helpline, and it'll be a great help for them. Coordinate with other NGOs working in the same area. For example, HelpAge India is there. There's a Goa chapter of HelpAge that does a lot of work. Coordinate with the Directorate of Health Services in its elder outreach programs. Now, in fact, the primary health centers have been told to go and address the healthcare needs of people in old age homes. So they do visit old age homes. They do take care of people in the old age homes as well. This is something that is mandated under the program for them. Coordinate with the Directorate of Health Services for that. And if as Dr. Montero mentioned, health camps not really the best thing, because of one-off thing. It creates a lot of awareness, and maybe a lot of goodwill, and people go back with calcium tablets and very happy about that, but really it doesn't have a big impact. But healthcare camps for these tend to have a lot of yield. So you do detect a lot of people with visual problems at health at camps for this, and this is something that the IMA has been doing for quite some time and can continue. So I will stop my presentation here. Let us all care for the old with a heart of gold. And you need to give your inputs. It's really going beyond your boundaries. It's not doing things that you always did. It's doing something different that is going to make a difference in the lives of older people. Don't forget the caregivers, and don't forget the multiple problems that they're having. All the very best. Thank you.
Thank you so much, Dr. Amit Dias, for your very informative talk. You have carefully enumerated and highlighted all the problems faced by the elderly population in Goa, and how we as the IMA can help in bringing a smile on their face by helping them out. So I think the house is open for questions now. So if any members are having any queries, you can either type it in the chat box or you can ask Dr. Amit Dias. Rohan, if you could unmute all the participants.
Hello, Dr. Amit, can I ask you one question?
Yes, sure.
Amit, how do there are a lot of physical abuse that happens in elderly people, and what sort of protocols are there for them to sort of address these issues? Does the police have a separate cell, and how do they go about it?
So one thing that you can do, see, elder abuse is something that has to be dealt with very delicately. Elder abuse is definitely something that has to be condemned. But at the end of the day, they are living the same family. Whenever I came across some cases, I always referred to HelpAge, and so they dealt with it later. So they first speak to the family members and see what the problem really is, and see if it can be addressed at that level. If not, then it has to go beyond and go to the police, and the police will have to intervene. And there are laws that are very much in favor of the elderly. And so if they go through the police route, the collector and others can intervene, and action can be taken on the family who is abusing.
Okay.
Yeah. Thanks for all the comments in the group. I'm just seeing, there any questions?
Yeah, as a question, Dr. Amit, by Dr. Linda Bhatkar, can there be a rule that doctors' consultation room should always be on the ground floor? Because
they can't be
clinics in the city with elevators that are so difficult to access for the elderly.
Yeah, that's exactly the issue that was brought up by one of the members in that group. And as I said, they said especially the clinics in Margao, I don't know whether that is true, it may not be true. Clinics in Margao, I said, are very difficult accessibility is a big issue. So taking somebody who's old to that place becomes an issue. And we don't even have so many general practitioners who at one point of time would visit home. So getting a doctor visiting home also is becoming a big issue now. And so the older person with a problem tends to be neglected. So can there be a rule that the clinic has to be on ground floor? I don't think that can be enforced on, it's like it would be really harsh on the doctors to enforce that. But when you're building a clinic, if you can think in terms of that, you can think that the door has to be a little broader so that a wheelchair can be wheeled in. And the place is non-slip. There is a lot of place for them to sit. There is a special probably line for older people, and probably an appointment system for older people. That is something that would help. That would be useful. But we need to think on those lines. There is a rule for government hospitals. So all these government hospitals have to be disabled friendly. They have to have ramp, etc., etc. So, but no rule for your private clinic. It would be really harsh on you all.
Dr. Rufino, can I ask a question, Dr. Rufino?
Yeah.
Dr. Rufino, I think, is this possible for us to start like a COVID helpline, to start a geriatric problem helpline through IMA Tiswadi?
Yeah, that's exactly what, that is exactly what we would like to do. Identify the homes that we would like to look after, give them medical care by visiting, and definitely have a helpline as is suggested.
where we can give them teleconsultations for their problems, where the doctor need not go, or in an emergency situation, advise them what to do instead of wasting time searching for somebody to go there. Yes, teleconsultation would be, we will work towards that.
Yeah, I'll just add over here is that, as I said before, there is a helpline that the government has launched, the 14567, 1456, yeah, whatever the number is I mentioned. What I'm saying, don't reinvent the wheel, because a lot of calls on the helpline will be for social issues and for other issues that would not need medical help. Let all the people, educate people about that helpline, and they will filter the calls and send you the medical calls. Otherwise, you will be filled up with a lot of calls that are not really necessary, that's not in your domain. So let them filter and get back to you. We can actually the IMA can sign a small MOU with them, and this can be done very smoothly.
Yeah, that's a very good idea.
That's a suggestion. Yeah.
Dr. Amit?
Yeah.
Dr. Amit, we have another question
Sure.
from Dr. Himangini. Can you please share sources where caregivers can be hired for those who have no support system?
Yeah, what I can do is I can send that to you all, and you can then share it with the other people, because that's a very useful thing to have, where caregivers would be hired. But this is not free of cost. You have to pay, and I think different agencies charge differently. So I have a list of them. Maybe this is not an exhaustive list, but the list that I have, I will share with you, and you can share it with the others. It's a very useful list to have, though.
She also wants to know about retirement counseling.
Yes. So that is also I mentioned in my, we used to do it at one point of time. Everybody who is, this is nice captive audience. Like before they retire, if they are trained, they will be really interested in knowing what will happen next to them, and they're very attentive for this kind of a training. So a kind of a 3-day session for people who are about to retire at the age of 65 or maybe 62 or whatever the retirement age is, depending on where they are, to do this kind of training for them. So retirement counseling, very useful. What we noticed is that when it comes to retirement, women are always busy. After retirement, probably they're even more busier than before retirement. But the men are totally lost, and they don't know what to do beyond retirement. So how to plan that, how they can get engaged with something, what they need to get engaged with, and how they can actually assist with various other things. This is something that they need counseling. Otherwise, it does cause a problem. And probably an annual thing that the IMA could take up to do retirement counseling type of a training.
Yeah, Dr. Amit, we
Yes,
can work in close collaboration, especially to train the carers. That is something
Yes.
that will improve the care of these elderly people in the homes.
Yes. Yeah.
You rightly pointed out many a times it is the inexperience or the wrong attitude of the carers where the care of these elderly people does not really get on well. So I think we work on that subject of training the carers, training the paramedical personnel, and obviously have some of these people who will give them psychological support.
Yes, that's true.
Yeah, in the same context, Dr. Vishwaraj writes that they have a retirement counseling at Goa shipyard for all their employees.
Very good.
Yeah, this
very much needed here.
Yeah, counselors at every point would be good. Counselors for the old, counselors for those who are in the gray area, and also training the youngsters for counseling the youth, where they could definitely help in elevating the mood of these elderly people by various activities.
Yeah, and these counseling programs also could be not only focused on health, also how to deal with the finances in the future, etc., investments and things like that, which are very useful for them, because these are all things that actually ultimately affect their health. The financial health is also important for them.
Right.
Any more questions?
So there is a suggestion the IMA should motivate the government to have free old age homes. They do have, the Providoria homes are free. It's just that we probably need to improve the quality of care given through the Providoria old age homes.
Right.
So, you know, in your process of actually adopting homes, if the ones, some homes are pretty well to do. So
Right.
if you have, you know, you cannot reach out to all, then you reach out to the ones who need more help. So I think that would be.
So our aim is for that first, to reach out.
Yes.
We have some charitable organizations that do run these homes. So
Yes.
those homes we would like to really give aid first and
Yes.
help even the others as and when they need medical attention or help.
True.
Okay. Thank you, everyone. So if there are no more questions, we come to the last point. Hello, yes? Anyone? Any question, please? Okay. Can we have the address of the free service, Dr. Nutan Dev?
Sorry, that's a question to me.
Yeah. Can we have the address of
The
the free
address-
service? Yeah.
The fees run by Providoria. Okay, I can send that also to you. I don't have it off my head, but there are 9 centers run by Social Welfare Department in various parts of Goa, and I'll send you the list. And you can always, if there is any help required, you can reach there. The other homes, many of the homes are also free. For example, the ones run by the Missionaries of Charity, I think they are free. There are others that run at a nominal cost. So there are various types of services available.
Okay. So if there are no more questions, we come to the last part of our program today, and that is to propose the vote of thanks. I hand over proceedings to our treasurer, Dr. Swapnil Usgaonkar.
Thank you, Dr. Dalvi. On behalf of IMA Tiswadi and IMA Goa and the IMA members, I would like to thank Dr. Amit Dias, truly a doctor and human being with heart of gold, to sensitize us and motivate us to this sensitive topic of care of old age people. Your passion and devotion to the holistic care of elderly people is truly inspiring and commendable. Thank you, Dr. Amit, and good wishes for all your further endeavors in this field. We will surely try to take your vision forward through the IMA flagship. My heartiest gratitude to our dear IMA State President, Dr. Rufino Montero. Your enthusiasm, vision, guidance, and mentoring is invaluable. So we are truly lucky to have you to guide us. Special thanks to Mr. Rohan to provide a digital platform in this COVID times. Finally, a big thank you to all IMA members to attend in big numbers and to make this event a success. So with the eternal hope to meet further in person for a physical CME, thank you all and good night.
Okay.
Good night, everyone.
Thank
Thanks
you.
for the invitation.
Night.
All the very best to IMA. Long
Good
live
night.
IMA.
Long
Good
live
night. Good night, guys.